Welcome to the Gas Exchange podcast, where we talk about anything respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. My name's Keith Lamb, and I'm the host. I'd like to welcome my co-host, Thomas Perino, and today's guest, Dr. Thomas Bleck. Dr. Bleck is a world-renowned neurointensivist and founder of the Neurocritical Care Society. I've known Tom for, I joined the critical care listserv in 1997 as a trainee, and I'm sure you were a member either then or maybe before then.
A little bit before.
Yeah, because it was just developed like maybe a couple years before that. So we've virtually known each other since 1997. Today we're going to talk about things that interact with respiratory critical care in terms of neuro intervention. And so, can you tell us Tom, can you just tell us a little bit about yourself real quick?
Well, I started in internal medicine and then decided I was really interested in neurology. So after medicine, while I was a neurology resident, I was also a MICU attending at Rush. And then after my fellowship in epilepsy, I was doing a fair amount of time in what was then an unusual thing, which was surgical epilepsy. So I had time spent in the surgical ICU, and then in 1985, we got a new chief of medicine, a guy named Roger Bone, who many of you will be familiar with. And Roger was a real intensivist, a pulmonary doc, and I think initially wondered who's this neurologist hanging around in my intensive care unit, but eventually called me in and said, Bleck, by constitution, you're an intensivist and you should just admit this and get on with your work. So I had enough time in practice in the MICU and SICU to qualify for the American Board of Internal Medicine's critical care exam. And once I had that piece of paper, then people started recruiting me to run a neuro ICU. So I was a medical intensivist and a neurologist, but there were almost no neurointensivists then. I was lucky enough to move to the University of Virginia in 1990 to open their neuro ICU, and really had to just kind of figure it out as we went along. I was very lucky to have the assistance of both some really great medical and anesthesia-based intensivists, John Truitt and Charlie Durbin, and also a lot of support from the attending neurosurgeons. Neurosurgery residents weren't so sure they wanted somebody in their way. They thought the ICU belonged to them, and I often had to disabuse them of that notion. But over time, we developed both a clinical and research program, which eventually led to forming the Neurocritical Care Society in early 2000s. And it's, the whole field has really grown considerably now. Almost every academic medical center has a neuro ICU run by neurointensivists. They're sometimes in the Department of Neurosurgery, but usually now in the Department of Neurology. And increasingly, private practice hospitals also have neurointensivists. Not so often their own unit, but often working in mixed medical surgical units. So that's how I got into the field. I'm still also an epileptologist, so I'm very interested in the electrophysiology of critical illnesses, but that's getting a little off topic for today. I learned my pulmonary actually as a visiting student at another institution, because in the mid-70s, what we now consider pulmonology barely existed. I had to go to another place to learn how to do fiber optic bronchoscopy because none was being done outside of the thoracic surgery department where I was being trained. Of course, now this is very standard. I learned ventilators on the MA1 with the external spirometer that would go up and down. And the alarm on it was if the spirometer didn't go back up, the alarm would go off. Anyway, those were the old days.
Yeah, we see those in the movies. I've actually seen one. We had one in PACU where I trained that they used, but Charlie Durbin, that's a name from the blast from the past.
Sure.
He's an anesthesiologist that was very involved in the Virginia Society for Respiratory Care and at University of Virginia.
Charlie later became the president of the Society of Critical Care Medicine as well. So
But I don't think that I knew that.
interested in that. I saw the last iron lung in Virginia and convinced the patient who was in it to get a trach and go on positive pressure ventilation at night, which improved his life considerably. And now that iron lung occasionally gets trotted out as a museum display, but hopefully we won't see them coming back. Although negative pressure ventilation with the cuirass might be useful in some areas.
Every time I see a video of someone that was still in an iron lung, I always question to myself, well, what makes them choose that over the ability to be trached and come out of the lung? And do you think it's mostly psychological at that point, or fear because they'd been in it for so long? Or
yeah, I think at least for the one that I knew, it was psychological. I think the ability to have spontaneous speech, which, if you got a passing mirror valve, you could probably arrange a similar thing, was that. Mm-hmm. But, the ability to
communicate is huge, really, yeah.
Right.
Oh, yeah.
The ability for, typical skin care, for example, is so bad in an iron lung. I don't know why anybody would want to stay there.
Mm-hmm.
I've seen a few people on rocking beds, which, sort of, if you're marginal, that'll be enough to move your diaphragm up and down. Not having parasternal intercostals is just a really bad thing if you needed to cough, though. So,
right.
Yeah, the ability to communicate cannot be overestimated. Some of the one of the most rewarding things as a clinician is to allow somebody to talk for the first time in weeks, after they get trached, and put that valve on and their face lights up and their family gets excited and they can actually tell us what they need. That's definitely underappreciated.
We could be doing a much better job for people who need to remain endotracheally intubated for a little while with sort of speech mechanisms that are driven by your eye positions. It's quite capable, or the system is quite capable of working with those patients, assuming they don't need a lot of sedation, but we really haven't made the investment to allow them to communicate. They still use letterboards where I am. So.
Yeah, we looked at, when I was out in Iowa, we actually worked with speech, and we looked at the use of the device that folks have that have laryngectomies, the EVOX or whatever that is called.
Mm-hmm.
And you can get somebody to talk that's endotracheally intubated. You can understand what they're trying to say to some extent. And I agree that I bet you there are ways to improving software and improving the definition of that.
I think we're not too far from being able to do this with surface EEG, which would be another big advance. Wouldn't require invasive devices the way the current systems for generating speech or movement work.
Wow. Very, very interesting. So I think that something I'd like to start with kind of is something that you and I, Tom, talk about, Dr. Bleck and I talk about probably twice a year. And it's only because he'll never forget the information that he's passing on, and I always forget the information. But the interaction between, so if you work with trauma patients, in my 28 years, I have predominantly worked on a trauma service and taken care of a lot of trauma patients. And part of those, at least some of those patients have been patients with traumatic brain injuries and intracranial hypertension. And we've gone from way back when I started to wanting to hyperventilate those patients to control their ICPs, to today what I think that the standard is to not hyperventilate, but just keep the CO2 on the low end of what's normal. Can you address that and not only address that particular topic, but address what really makes the ICPs go down when you hyperventilate somebody? It's not just the carbon dioxide level that changes, right?
Right. So the thing we can manipulate easily is the PaCO2, but the cerebral blood volume, which is how you're manipulating things that way, is dependent on the pH. Now, since buffers don't get across to the brain with any reliable speed, it's only the carbon dioxide we can manipulate. So when you start saying that the ICP is going up and I need to buy a few minutes for my hypertonic saline to bring down the ICP, or I need to get to the operating room, or if it's someone with tumor-related increased intracranial pressure, time for steroids to work, then you can certainly hyperventilate somebody. Now, why we keep people sort of at the low end of the PCO2 range, say around 35 or so, goes back to a study that was done at the Medical College of Virginia that said, well, if you leave them to their own devices, they generally hyperventilate a little bit. So we'll make this the control group, keep the PCO2 around 35 or so. And then they used a comparator group where they hyperventilated them down into the mid-20s. And what you see when you do that is, yes, you get a dramatic drop in intracranial pressure to start with. But things are always working against you. The homeostatic mechanisms, when you make the brain that alkalotic, a few things happen. One is that the choroid plexus immediately starts exporting bicarbonate to bring the pH back down. Or if you're a fan of the Stewart acid-base system, you say that it's exporting some strong ion and the bicarbonate is following. I think it doesn't really make a difference which one you believe in. The point is that the pH is coming back down. And when that happens, the vasoconstriction that resulted from alkalosis, because the arterioles are sensitive to the hydrogen ion concentration on their outside, start to dilate again, right? So that works against your attempt to bring the intracranial pressure down. Secondly, as soon as you say, well, I brought the ICP down by hyperventilation, but 2 hours later it's back where it was, maybe I should hyperventilate a little bit more. Well, that's okay, except you'll reach a point, as you guys know, where you will start either increasing the tidal volume or increasing the rate to the point that you start stacking breaths. Once you do that, the intrathoracic pressure goes up. Now you're impeding jugular venous return, which is something important to keep in mind, even if you weren't doing this for the purpose of lowering the intracranial pressure. Whatever you do that raises intrathoracic pressure is going to decrease flow back out of the jugular veins. That can increase intracranial pressure. Now, if your brain is normal, you can probably tolerate that to quite a degree. People in the operating room have done these apneic oxygenation experiments where they keep the patient oxygenated, but the PCO2 climbs considerably, the pH goes way down. And if your brain was normal, you could tolerate that. But I've had the experience where somebody already has an intracranial pressure monitor and needs to be reintubated. And you can very quickly see, you've hyperoxygenated them and probably hyperventilated a moderate amount, but even in a minute or two, passing an endotracheal tube without any ventilation, the ICP starts to rise. On top of which, by the way, the whole motion of direct laryngoscopy seems to also impair jugular venous return. I've seen the ICP go up to 100 during an attempt to ventilate somebody or to intubate somebody that took more than a minute or so. So anyway, the first one was the pH is being corrected by the choroid plexus. The second is the rise in intrathoracic pressure, impairing jugular venous return. And the third is whatever was causing the increase in intracranial pressure is usually progressive. So you bought some time in doing that, but if you can't fix the underlying problem, then the ICP will go back up again. And now you're stuck at a new baseline PCO2, and you really don't have much room to move. So it's fine when you need something very quick. It's clearly the fastest thing you can do. Somebody who blows a pupil because they're starting to herniate, often the pupil will come back down within a minute or so of starting to hyperventilate somebody, even modestly. But you need to have something more definitive to keep it going.
Yeah, it's
or
just
like
buying
like
it.
a
It's just
cranial,
buying you time at that time.
right?
But
For craniotomy or
Mhm.
yeah. So I've been told. So the way I've always explained it, so I hope it's correct, is that you give away cerebral perfusion when you hyperventilate and you cause vasoconstriction, right? And there was a study that showed that compared cerebral lactate levels with global lactate levels during hyperventilation and showed that the cerebral lactate levels were much higher than the global lactate levels, meaning that the only place that was um, that hyperventilation was affecting perfusion was the brain. Is that a good way to describe that?
I agree. The brain is usually a net consumer of lactate. So if you measure arterial versus jugular venous lactate, it's usually lower in the jugular vein.
Mm-hmm.
When you produce ischemia, however, the other thing to keep in mind is that you have a local acidosis developing related to that lactate, and that will start dilating vessels again. So we don't really know where that threshold is, but the areas that are most ischemic are probably not being well controlled with hyperventilation. And if those are the ones that are swelling, you might wonder if you might even increase shift if it's a focal problem by constricting vessels in the rest of the brain and not where the swelling is. Uh, that's been difficult to demonstrate, but it's a theoretical concern.
So, if you were to sort of try to wrap that up for the bedside clinician that manages the ventilator, it's okay to hyperventilate acutely if you're trying to temporize the effect of ICP until you can do it, until you can intervene, like with a cranie or hypotonic saline or whatever the different things are that you guys do. But in terms of standard care for somebody who's got a TBI, then it's okay just to keep the CO2, let's just say, lower than 40. Does
Yeah,
that
so
make sense?
there was a study in stroke patients who also tend to hyperventilate spontaneously, in which they paralyzed a group of them and kept their PCO2 at 40. And the mortality was actually higher when you did that than the control group. Now, maybe that was the effect of otherwise unneeded sedation and neuromuscular junction blockade rather than just the effect on pH. But there seems to be no benefit to trying to quote unquote normalize it. Why the brain wants you to do that, we really don't know. Doesn't seem to be any sort of local acidosis in the brainstem where the pH is being sensed. At any rate, it seems reasonable to do that. The study that people point to where they uh, had the experimental group with the PCO2 in the 20s, by the way, is often held up as a reason why you shouldn't chronically hyperventilate somebody. However, the measurement that led people to say that they should stop the study was that the uh, Glasgow outcome scale looked a little bit worse in the patients who were chronically hyperventilated at 3 and 6 months. But by 12 months, there was no difference. So it may be that the compensatory mechanisms sort of brought things back to something acceptable, or that people were smart enough not to let the intrathoracic pressure rise too much. At any rate, the prohibition, quote unquote, on long-term hyperventilation probably isn't as well backed up, but it doesn't seem to work for a long time. I think once you've hyperventilated somebody to do some other treatment, though, you should probably bring them back to a relatively normal pH fairly slowly rather than just automatically saying, let's go back to tidal volume of 400 and rate of 12.
Yeah. So this is so as you know, the paradigm shift over, I know, at least since year 2000 has been to sort of protectively ventilate patients, and even more recently, not only protectively ventilate patients, but do a more concierge, individualized approach to each individual patient, and sort of dose and fine tune things. And we know that tidal volume since the year 2000, driving pressure today, P Silly, Villi, all of these things, and so all of these approaches sort of and and allowing some hypercarbia if it means that by allowing permissive hypercarbia so that you can kind of stay within those protective parameters of mechanical ventilation. And so that sort of made, how does that maybe more difficult to manage TBI patients? How do you think that plays into it?
Yeah, so, there are two recent publications from the VentiBrain group, which is worldwide, but predominantly in Europe, that suggests that for most of the patients who they had some way of measuring intracranial pressure, although they don't mention how they were doing it, that within the range that we find acceptable in terms of tidal volume or driving pressure, there didn't seem to be a problem with intracranial pressure. And in fact, this is not a randomized trial, it's observational, but people who got higher tidal volumes had increased mortality just like everybody else does. And there didn't seem to be a neurologic problem in terms of the Glasgow outcome scale score in people who got low tidal volume ventilation or whose driving pressure was kept under 15 centimeters. So from what you can read in the literature, there doesn't seem to be a problem doing it. Now, there are two problems with this. One, those papers don't report what else was being done to manage intracranial pressure.
Right.
And in many other studies, we've seen that people try something, they say, well, it's safe to do it, or this was bad. But what they didn't report when you go back and look at the data is that we gave a lot more other treatments to compensate for it. So I can't tell from the VentiBrain studies just what else was being done. Now, their mean intracranial pressures were actually at the upper limit of normal. So whether these were patients who weren't suffering as much from increased intracranial pressure or whether they were getting ventricular drainage and the pressure was staying at 20 because they had the ventriculostomy pop off at 20, so it would not go higher, or they were getting hypertonic saline or mannitol or whatever the current en vogue thing was in those centers.
Yeah, this is extremely important when we think of analyzing clinical research, is that if you're not reporting or recording or collecting the proper data for confounding factors, it doesn't really help to answer any logical questions. You see outcome, associations, and you're like, okay, great, but where are all the confounders and how did you control for them? And did you analyze or reanalyze? It becomes very challenging, and ICP is a whole nother, like you said, a ballgame. Like, are they getting hypertonic saline, or do they how are they managing it? That's a huge factor. I didn't realize that was kind of missing in those studies.
Yeah, absolutely. I think the population that I would be more interested in would be just people who you're having trouble with their intracranial pressure to start with, right? So the majority of patients in trauma settings will have a couple days of some increase in intracranial pressure, but often it's not as dramatic, or it was terrible and they died and you didn't have a chance to study whether other interventions had an effect. I think, though, that if you could concentrate just on the ones where you're having intracranial pressure problems, say, you would look at in the craniectomy trials where they have an intracranial pressure that remains over 22 despite our typical medical management, that'd be a population where it would be important to know what effect ventilator parameters are having, especially related to intrathoracic pressure in somebody with polytrauma, where you may have either elevated intrathoracic pressure to start with, or you may have lungs that have gotten stiffed from ARDS. Those are the people I'd like to know more about, but there's been very little work in really figuring out what goes on with their brains. Now, when we see them, my notion is I will do what I can to let their PCO2 rise if that's necessary for their lungs, usually meaning more hypertonic saline, more sedation, setting them up because they'll improve jugular venous return to some extent. We used to use hypothermia, which will lower intracranial pressure a little bit. However, it doesn't seem to affect outcomes, so most people have left that as a last ditch treatment. Neuromuscular junction blockade will usually lower the intracranial pressure in patients like that a few millimeters of mercury. How it's doing it isn't clear. I've sort of assumed that they have either undiagnosed abdominal compartment syndrome or that their intrathoracic pressure is high because of whatever extrathoracic musculature is compressing it, and by relaxing that a little bit, you got a little better jugular venous return, but there's no way to measure that. It is important to keep it in your armamentarium, though.
You highlighted an interesting connection, the intra-abdominal compartment syndrome and the brain, like two opposite ends of in terms of patient thinking, right? You're focusing on the brain, and you may be ignoring the fact that you have significant abdominal compartment syndrome that is actually impacting that. And, I think as respiratory therapists, we always joke that we deal from the diaphragm up, but even abdominal compartment syndrome extremely impacts even mechanical ventilation in general, not just the brain, but the impact, because it's part of the chest wall. But we often don't consider like what is happening in the abdomen. It's one of those things that's like, this focus of north of the body is sometimes problematic because you completely miss these important issues.
I saw Tom Scalia from University of Maryland give a talk several years ago about how he performs therapeutic laparotomy for ICPs, because all three of the compartments are sort of, although they're separate, they influence each other. So if you decrease the pressure in the belly, then the chest pressure decreases, and if you decrease that, then the ICPs decrease.
Right. So, in abdominal compartment syndrome, people don't measure CVP that often anymore, but the CVP is often high, and yet you have trouble maintaining mean arterial pressure because you don't have adequate venous return. Mm-hmm. If you measure ICP while the abdomen is being opened, you see a tremendous drop right away in people who have abdominal compartment syndrome. Yeah. Of course, then the air output goes up, and you have to catch up with the fluids that they're going to lose. But it's quite dramatic if you watch for it.
Yeah, we talk about abdominal compartment syndrome a lot in the respiratory critical care sort of circles, and how that influences airway pressures and esophageal pressure and transpulmonary pressures. And we talk a lot about morbidly obese patients. As a matter of fact, we just talked a couple of days ago during one of our podcasts about how the magnagement of PEEP is determined by extrinsic influence on airway pressures, including intra-abdominal hypertension or high abdominal pressures, but also because of morbidly obese patients. Do you think that somebody with really high BMIs would influence their intracranial pressures also?
Well, I think it does. The issue of how much PEEP is transmitted into the venous system, depends in part on how stiff your lungs are. But I don't think maybe somebody have that I don't know about, but to the extent that increased weight of the chest wall also influences the ability of, the PEEP to affect pressure within the venous system, I think is important. It looks to me like it does increase it, but it also can result in decreased venous return. I think, the people who have put in esophageal balloons think that you can sort of ignore the actual pressure and just subtract out what the chest wall is contributing to it. But I haven't seen that sort of work done in people who have increased intracranial pressure to see how it affects it. My guess is that it does.
I used to really confuse the nurses when I'd ask if they had measured bladder pressure recently. They're like, why is the respiratory therapist asking me? And this would be in the absence of me having an esophageal balloon to determine whether or not chest wall compliance was an issue, likely related to the abdomen. But yeah, it used to throw them off. But in one hospital where I worked, it became actually quite common that if someone had if we were having ventilation difficulties, we actually would investigate the abdomen. Like our threshold for investigating was actually quite low due to a case that we had with a patient where we put an esophageal balloon in, and the required PEEP was excessively high because they had abdominal compartment syndrome. And then, of course, once they tapped the abdomen, it was a very different case. But it was a case report that we published. But after that fact, it was surprisingly how many times we measured bladder pressure, and we kind of felt that we were sort of ignoring how this affects everything, including just ventilation. But I don't know if that's overall, if that's taken off clinically. Like, Keith, do you feel clinically you see a lot of bladder pressures being used, or is it just on specific patients? Or
yeah, we probably see it done more often now than we used to 20 years ago, but it's typically done in a specific patient. It's somebody that we suspect is having, negative squalor from an intra-abdominal process of some sort.
I think it often goes unnoticed. I mean, even just with, aggressive fluid resuscitation, you impact the abdominal pressures for sure. And I think it would be one of those useful baseline tools and measurements done routinely. What do you think, Dr. Bleck? Do you think this is something that should be routinely assessed before we're wondering whether or not this is a problem?
Yeah, well, as an old-time clinician, I think if the abdomen is soft, then the bladder pressure can't be very high.
Fair.
If the abdomen is getting firm, I don't know whether the pressure is dangerous or not, and then I think it needs to be measured.
Something more objective, yeah. That makes sense.
Yeah, sure does. Neurogenic pulmonary edema. What is that?
First, the people who get neurogenic pulmonary edema typically have some disease that has produced a rapid increase in intracranial pressure, or there are forms of encephalitis that affect the brainstem where you get a problem of neurogenic pulmonary edema from some direct brainstem involvement. The place where we see it most commonly, though, is in subarachnoid hemorrhage. And although we don't know early on in a hemorrhage how high the ICP got, if people lost consciousness at the start, you can assume that their intracranial pressure met or exceeded their mean arterial pressure, which is why they would lose consciousness. But neurogenic pulmonary edema is something that is often underestimated. We went back and looked at blood gases when people first got to an emergency department and showed that although only 20% of them were hypoxemic, there was an elevated AA gradient in 80%. This was before people started giving them fluids. Now, some of them could have aspirated. I can't prove that none of them did, but there is, I think, quite commonly an increased AA gradient. The animal models for this show that what you actually get is a neurogenic constriction of sphincters on the pulmonary venules, so that the pressure in the pulmonary capillary goes up and you get transudation of fluid. About half the patients, if you do BAL, have a normal protein content in the fluid, and the other half have an increased protein content. And in the animal models, you can show that the more severe increase in pressure can result in capillary fracture in the alveolus, so that you have not just fluid transudation, but you actually have leakage of albumin-containing plasma. If you put in, as we used to do, a PA catheter, though, you wouldn't see that the left atrial pressure, as estimated by the wedge, was elevated, because the issue is at the venular level, not raising the left-sided pressures in the heart. Luckily, when this happens, it's usually going to be gone in 3 or 4 days before they get into the period of risk for vasospasm, which, we often are giving extra fluid then, but here we want to decrease lung fluid, usually by modestly drying them out. But also, I don't dry people out very much anymore for anything, but unless they've been over-resuscitated, and that's going to happen days later. I think the main thing that we can do for it is to just increase PEEP. And, if they have another problem that occurs at the same time, though, which is the Takotsubo cardiomyopathy, also occurring usually quite abruptly after the onset of subarachnoid hemorrhage. And there you do get elevated left-sided pressures. So these days people, do echoes to estimate this. But when we put PA catheters in people, we would find some who had elevated left-sided pressures resulting in pulmonary edema, and others who had normal left-sided pressures and had the neurogenic mechanism. The animal studies that look at this basically show if the lung is denervated, that you don't get edema in the denervated lung, but you get edema in the lung that still has normal innervation. And the denervated lung usually involves cutting off the lymphatics as well. So you'd think if the lung lacked lymphatics, it'd be more likely to develop pulmonary edema, because all of us clear out interstitial fluid through the lymphatics. And yet, if the venules don't contract, they don't get pulmonary edema.
The salt, hyponatremic, any of that play into pulmonary edema?
Probably not too much at the start. I mean, the subarachnoid hemorrhage patients, who make up the vast majority of people with neurogenic pulmonary edema, usually their ICP came down or they got a ventriculostomy to lower it. Nowadays, there's a school of thought that you could do the same with a ventricular, or maybe with a lumbar drain. Either way, if you get the ICP down, you aren't likely to see as much of a problem. It would make sense to say if you kept somebody with a serum sodium of 155 or 160 that you might expect more transudation, but I think we're usually just compensating for that. In the trauma patients, where you might be keeping them hypertonic for several days, luckily neurogenic edema is not nearly as common. It's not unheard of, but it's not that common a thing.
So for the bedside clinician, it's fair to say that regardless if it's neurogenic pulmonary edema or whatever the etiology of the pulmonary edema is, that the same sort of rules apply. More PEEP. Mm-hmm. If it's a diffuse alveolar edema, then more PEEP, cautiously, and then of course the same rules of mechanical ventilation apply in terms of energy and driving pressure and things like that. Would you agree with that, Tom?
Absolutely.
Oh yeah, there's two Toms. I would also agree. Yeah. I'm sure your question was directed towards Dr. Bleck, but yeah, I'll answer it too.
Both of you.
I agree. Yeah.
Tom squared.
So the other thing to keep in mind here is that if the patient's also in need of CVVH, then you need to figure out how you're going to manage the osmolality in the solutions. So your standard CVVH is going to be dialyzing somebody against a sodium of about 135. And you may need to add hypertonic saline into the return circuit to prevent that from lowering the serum sodium and keep the intracranial pressure down that way.
Man, that dang dialysis confuses everything, doesn't it?
Right.
Now, this may be a dumb comment or question, but often I feel like oftentimes when we get patients with potential head injury and then we look at an x-ray, like they come in respiratory failure and it very well could be this neurogenic pulmonary edema, we often ask the question like, oh, the x-ray looks bad. Maybe they aspirated. And like it very well could just be pulmonary edema. And likely the answer would be that if you apply PEEP and if you apply appropriate PEEP and it's completely resolved, it likely wasn't an aspiration. But I wonder if we often just sort of jump to, because it's head injury and the x-ray looks bad, perhaps they aspirated. And again, there would be hints if it would likely be just right-sided, et cetera. But I wonder if there's some conclusions being jumped to there when it's likely just something that we're not naming, because I haven't heard many people talk about neurogenic pulmonary edema, like pulmonary edema, sure, but linking the two as a sort of a common trigger being the head injury. I wonder if there's some misdiagnosis there initially.
I think there certainly can be. People have tried doing early bronchoscopy and sorting that out, and I'm not sure we have a complete answer for it. But a lot of the head trauma patients we encounter are in motor vehicle collisions where the right side isn't necessarily going to be where they aspirate. It depends what position they're in.
Fair, yeah. They could be completely lying on a different side, yeah.
I think the other thing I didn't mention there was people get negative pressure pulmonary edema if their upper airway is not working right. So if they have facial trauma and they try to inhale against a glottis that's damaged and get negative pressure edema from that, obviously those are folks who are going to end up correct or trach pretty early.
That's essentially the first description of patient self-inflicted lung injury is this negative pressure pulmonary edema is the first. That's like the historic representation of that. Yeah.
It's complicated. Like they say, if it was easy, everybody could do it, right?
One of my trauma surgeon friends said, we're going to keep all the head injured patients in the surgical trauma unit for 24 hours. And please give me a one-page description of how to manage intracranial pressure. So I wrote down, call me.
2-word description. That's awesome. So we don't have a ton of time left if we want to keep this less than an hour, but a big topic today is certainly ventilator-induced brain injury. That's something that's been talked about, looked at, studied, et cetera. What are your thoughts, your initial thoughts on that, Tom?
So I think the preclinical literature is pretty clear that larger tidal volume ventilation in animals results in a variety of different brain lesions. It's been more difficult to show this in humans just because we aren't usually sampling them while they're alive, and the ones who die typically have had so many other possible reasons to have brain lesions, including sepsis itself in the absence of septic cardiomyopathy or the need for really extreme treatments of ARDS produces brain injury. People who get MRs in the course of sepsis often will have multiple small hemorrhages that occasionally have been associated just with high ventilator pressures, but often if they were septic, they have lots of coagulopathy, they have embolism, some of them actually have microabscesses. So it's been hard to sort this out in humans, but I think every animal model that's looked at this in detail has shown that high tidal volume ventilation has its own deleterious effects on the brain. The cytokines that go up, of course, when you don't know what you're talking about, you can always blame cytokines and everybody will just agree with you. But
a lot of head nodding about the cytokines.
Right. But it does appear that cytokines that go up in the setting of ARDS have the potential to produce brain dysfunction. To what extent they produce structural lesions remains to be determined.
Yeah, so we know that a very small percentage of, so we know for sure, particularly from the lung safe study, that mortality for moderate to severe ARDS is still 40%. No matter where you're at, you could be in Charlottesville, Chicago, Florida, that doesn't matter. And we also know that a very small percentage of those people that do not survive from ARDS actually do not survive because of hypoxemic respiratory failure. Most of them die from multi-system organ failure, and we think the cytokines are to blame, right? That this inflammatory cascade, this secondary inflammatory process that occurs when the sick lung is ventilated with positive pressure circulates and involves other organ systems. So it would make sense that same mechanism could cause brain injury, just like it causes kidney injury, liver injury, injury to the gut, et cetera, et cetera. Would you agree with that?
Yeah, so I think one of the things that we need to understand a lot better is the transition from the pro-inflammatory or M1 macrophage morphology to the so-called healing or M2 morphology, where you have a shift in the cytokines from pro to anti-inflammatory. And it's likely that if we used steroids, for example, to try and trigger that switch. We need to have a better way of knowing where in the damage and healing processes we are. It may well be that, at the right moment, steroids would be great or other immune modulators, but given too early or given after the damage has been done, maybe the horse is out of the barn already. So it's a lot more we need to understand, but all the same things that happen to macrophages in the periphery happen to microglia in the brain. And they're pretty much controlled by the same mechanisms. In fact, half of those microglia were bone marrow derived macrophages that made their way into the brain. So it's a long way of saying we don't know what we're doing.
Well, I can say that in 1,000 different ways. I only understood a very small percentage of what you just said, but yeah, I guess it's fair to say that when we're talking about traumatic brain injury or secondary brain involvement from mechanical ventilator or negative pressure, pulmonary edema, or subarachnoid hemorrhage, et cetera, that the theme is the same, right? That we need to look at the patient that's in front of us, and we need to customize our approach to that patient, and we need to protectively ventilate them so that we don't trigger a secondary injury, which very well in this case, the discussion today could be the brain that suffers from injurious ventilator management.
So one thing we didn't touch on, I wanted to bring up though, is in the study that looked at high tidal volume versus normal, people are pretty well settled on that. But if you look at the conservative versus liberal fluid side, this was done a long time ago by comparison to the way we think now. So the measures of what was liberal and conservative were static measures rather than the dynamic ones we might use now. So, they were based on wedge or CVPs to say that somebody was either liberal or conservative. Everybody looks at the original publication and said, well, if you're in the conservative fluid arm, you spent less time on the ventilator, you spent less time in the ICU, and you had fewer days of what they called brain failure, which was basically looking at GCS. But Mark Mickelson, when he was at Penn, was able to follow up a subset of the patients and showed that the ones in the liberal fluid arm had better CNS function, mostly better executive function from frontal lobes, than the ones who were in the conservative arm. And I've always been worried about that and thinking, if it was simply a question of survival, then it would be better to survive. But if among the survivors, the people in the liberal fluid arm did better neurologically, but had to spend a couple extra days on the ventilator, I'll take care of them on the ventilator a little bit longer. So I think Mark has now got an R01 to look at this prospectively, and I think this will be a very important information to come out in the future.
Yeah, it's difficult to determine which outcome is most important to patients, and oftentimes it's quality of life and cognitive function. It's, just as you mentioned, spending another couple extra days in the ICU is not, in 2 years from now, they're not going to know that that was an issue for them. But if they're still struggling with cognitive function or quality of life, anything, activities of daily living, that sort of stuff, obviously that's the more important aspect for them. Mm-hmm. So that's an important question to answer for sure.
Yeah, geez, sure is. One more thing real quick that you mentioned the GCS, and I've always been intrigued. And, in respiratory critical care, we talk about GCS thresholds for intubation but are we using that test appropriately? Like, we see it's crossed over into evaluating patients that are drug overdoses, for instance. And, drug overdose GCS of less than 6 might not be the same thing as a TBI GCS of less than 6. And a drug overdose can oftentimes be rapidly addressed and sort of at least quasi-reversed. Should we be using GCS for that, Tom, or should we be using something else?
I think when this was first done, it was reasonable to say gee, if the GCS is 8 or less, maybe they're not going to be able to protect their airway well, and therefore we should intubate them. I think, as you pointed out, alcohol or other drug abuse patients who come in with a GCS of 7 or 8 may still be protecting their airway and may clear up quickly enough that any potential benefit of intubating them may be undone by the risk of inducing aspiration or whatever bad things we might do in the course of intubating them. I think that maybe a little more care in trying to figure out how good their airway protection is might be useful. And I think it's also seems to be becoming clear that for as great as my emergency responder colleagues are, that often intubating out in the field is worse, at least for head trauma patients, than carefully bringing them in to get their stabilization done in the emergency department. I hate to say that, but I think you need to think about it when you're planning emergency services. What's the best thing to do for the patient? And maybe trying to intubate them on the ground when it's raining won't be the right answer.
Not as safe as just bringing them in. Yeah, sure.
On the other hand, if everybody switched to using glide scopes or something, maybe the answer would be different. But right now, might well be that if you need airway control, maybe an iGel is a better approach.
Yeah, that's hard to disagree with. So, so another case of individualizing care for the patient, not just some thoughtless algorithm that everybody gets intubated if they're this, or everybody gets the same ventilator settings. There's just more thoughtful, individualized care. So that seems to be the theme for just about everything.
Right. Well, I think you need
it's
to
definitely a
know
repetitive theme for every podcast guest we have. Is at the end, it's like, so we really should pay attention to the individual patient.
Yeah, let's don't hurt the patient first. Let's think. What there's a saying that you guys physicians say.
I think you need to know the guidelines and then know when you should deviate from them.
Right. That seems to be the trick.
Yeah, this was a nice discussion with our last guest. We actually talked about ARDS guidelines, and he was saying that these should be the foundation on which you make further decisions rather than the ceiling, right? It should be the floor rather than the ceiling. And this is where we get into individualizing the patient. Yeah.
Very good.
Excellent. Well, Tom, Dr. Bleck, thank you so much for joining us today. It's been a pleasure. It's always nice to talk to you. And we really appreciate your expert input here. It's very valuable. And thanks to Tom Perino for joining us today also. And
I'm just hanging out, really.
Yeah, just hanging out.
Just listening and learning, yeah.
Yeah, well, same for this one, same for me. But I always enjoy talking to you.
In 5 years, we should come back and decide which half of what I said was wrong.
For me, it's 80%. So you're doing a lot better. All right, gentlemen, thank you so much. Appreciate you. You guys have a